Welcome to National Single Payer. I'm Dr. Claire Cohen. We are a national grassroots organization that organizes locally in the struggle for national single payer healthcare. We are united by the common principles that healthcare is a human right, must be free from corporate profit, and must be achieved through national legislation. If you would like to support our work, please donate to our organization. We will periodically drop a link in the chat that you can click and then donate throughout tonight's event. Some housekeeping. Please introduce yourself in the chat with your name and city. Try to keep the chat conversations to a minimum. If we get our Q&A up and running, we will ask you to post your questions to our speaker in the Q&A. In the event that we don't, you can post your questions in the chat, but I suggest that you put question, the Q mark before your question so we can distinguish them. Our speaker will speak for about 30 minutes, after which Dr. Judy Albert will ask questions that have been posted either in the Q&A preferably, or maybe the chat. Dr. Anna Malinow will wrap up the presentation with some items in the chat. Now it is my pleasure.
Mark Fabian. Oh, hold on, Nick. Where's my thing?
Okay, so I'm going to ask people to put themselves on mute, please. Okay. As you come in, please put yourself on mute. Now it is my pleasure to introduce tonight's speaker, Dr. Margaret Flowers, a pediatrician, public health advocate, and nationally renowned activist. She practiced medicine for 17 years, first as the director of pediatrics at a rural hospital in Maryland, and then in private practice. After witnessing the corporatization of her profession, she became an advocate for national improved Medicare for all. In 2009, she was arrested at a Senate Roundtable on health insurance by Senator Baucus for standing and speaking up on behalf of single payer, as no representative of that kind of system had been invited to the roundtable discussion. On being arrested, she said, "Our first goal was to have a seat at the table. If we couldn't get a seat, at least we could expose the insincerity of the current attempted health care reform and show that single payer was being actively excluded." Dr. Flowers will be speaking on the impact of national single payer healthcare on American life.
Great. Thank you so much, Claire and Anna and everyone, for inviting me, for the amazing work that you're doing. I'm so proud of you for keeping this going forward. And I want to apologize in advance. I have a sick son who's 8 years old next to me, and hopefully you won't hear him during the call, but if you hear something, that's probably him. So it's wonderful to be with you. And this is a topic I love to talk about. There's so much that I could say about the ways that having a national improved Medicare for all could impact our lives. I know that many of you on this call already know what national improved Medicare for all is. I do want to just very quickly run through a quick summary of what it is for people who might not know. But when we talk about national improved Medicare for all, we're talking about a national system. So every single person everywhere in the United States and its territories would be in the system. It would be improved Medicare. So Medicare has some weaknesses in that it is not comprehensive. It does not cover things like dental and vision and hearing. Also, Medicare has deductibles and copays, things that people have to pay out of pocket, requires supplemental insurance. All of that would go away. This system would be comprehensive. And it would be, of course, as I said, universal.
Don't you want to eat out tomorrow?
And I think somebody's got
At the Waffle House?
Yeah.
Microphone on. John McKean. Yeah. Maybe if you could mute. Thank you. Okay. All right. So, so that's in a nutshell what National Improved Medicare for All is. It would be a system where everybody would be in it from birth until death, and it would be comprehensive and cover everything.
Okay.
And whoever
about
the
your
host might be able to mute folks.
No, I got coffee.
No, okay.
Muted. And it would be paid for progressively upfront through the government paying for it. And so we would contribute in based on our ability to pay and would not have to pay at the time of care. So let's get into it, because there's a lot of ways that National Improved Medicare for All can impact our lives. And Claire, I'm going to go for about half an hour, but if you need me to stop before that, let me know, since we started a little bit late. But anyway, so what are the first ways? Let's talk about the ways that National Improved Medicare for All would impact our daily life. So the first thing that comes to mind for me is that there would be no financial barriers to care. In the United States, unlike other countries, when people have an accident or illness, one of the first things they think about before seeking care is whether I can afford it. And that would go away in a National Improved Medicare for All system. The other thing is that people would not worry about financial ruin if they had a serious accident or illness. As you know, medical illness or illness is the #1 cause of personal bankruptcy in the United States. About 500,000 families every year that experience medical bankruptcy. This leads to homelessness. It leads to devastation of families just because someone in the family had an accident or illness. It also leads. It also leads people to make. I'm sorry. It also leads people to make difficult decisions. I know of people who have had a serious illness who have chosen not to seek treatment simply because they didn't want to bankrupt their family. They wanted to be able to send their children to college. I know, unfortunately, of people, a young woman I think of often, whose father committed suicide because he did not want to bankrupt the family. This shouldn't be happening in one of the wealthiest nations. It shouldn't be happening anywhere. Under National Improved Medicare for All, when we have an illness and we go to the hospital or the emergency room or the doctor's office, the first thing they're going to ask us about is what's going on with us, not do you have insurance? There's no gatekeeping of whether you get in the door or not. The first thing that they focus on would be your care. The other thing is if people needed specialty care in the United States, if people needed specialty care, and you wouldn't have to worry about whether the specialist you need to see is in your network or not in your network. If you needed to go out of state to get specialty care, you could do that. It would be covered. Likewise, if you're traveling somewhere in the United States or you have to move, you don't have to worry about whether you'll have health care or not. It will go with you. So that would give people that peace of mind as you're traveling about the US. Also, we know of all kinds of relationship machinations that people go through in order. Yeah, James Romer, you're not muted. And to get on the other person's health plan. I know people who have stayed in marriages who didn't want to be in those marriages so that they could have access to health care. People who stay in jobs that they don't like so they can have the health benefits, or people who join the military to get health care. We also know that people, I think that I mentioned this, sometimes divorce in order to be able to qualify for things like Medicaid, to lower their income so they can qualify for public insurances. Also for people who need long-term care, you would not have to experience what we do with Medicaid right now, where people have to spend down their assets and put themselves into poverty in order to be able to get the long-term care through Medicaid. So this is a form of induced poverty, and we know stories of people who have a spouse who needs long-term care, and so they have to give up their assets, and that leaves the other spouse maybe without a place to live or without enough income to be able to take care of themselves. It also creates a situation where there's less stress. If you have an illness, you don't have to worry about the financial part of it. All you have to worry about is, yeah, maybe if you could put it, Anna, on pin me, and what you need to do to take care of yourself. and not whether or not you can afford the care that you need, or all the hassle that people have right now fighting with insurance companies and going through all the paperwork that's very difficult to understand. All of that goes away. It also puts healthcare decisions in the hands of health professionals and their patients. So we would no longer have this middle person making decisions, medical decisions, really. We have administrators with no medical training who are making decisions about whether people can get care or not. And it's not about whether you need the care. This was what I experienced in practice. They didn't really care about what was the best thing for the patient. They made decisions based on what they could get away with and denying care so that they could make profits. So this would really put those healthcare decisions, get that obstacle out of the way and allow patients and their health professionals to make decisions. And the way I kind of look at it is the current system that we have really pits health professionals and the patients against each other. The real culprit is the private insurance companies that are driving the decisions that people make. But health professionals are frustrated with it, patients are frustrated with it, and they can often take that out on each other instead of recognize that it's really this third party that's the obstacle. Let me talk a little bit about the impact of a national improved Medicare for all on jobs and businesses and also labor unions. Well, the first thing is for people who are working is that, as I said earlier, you don't have to worry, you don't have to stay in a job that you don't like to keep your health insurance, where it's with you from birth to death, wherever you go in the United States or its territories, you're in National Improved Medicare for All. And so you don't have to have that stress that you have portability of health insurance. It goes with you where you go. Also, right now, so much of our wages, when you do have an employer that provides health benefits, goes towards paying those health benefits. And each year, you really have no idea how much that's going to rise. And under a National Improved Medicare for All, it would be very transparent what the amount of contribution is going to be each year. It's something that people would be able to anticipate. So that would be not only a relief for workers, but also a relief for employers who, it's ridiculous. We require our employers or their HR departments to become experts in health insurance as they try to navigate that system for their employees. That's not what they went into most businesses to do. They want to be able to focus on what they need to make their own businesses better, not trying to understand our complicated and irrational healthcare system of health insurance. Under a National Improved Medicare for All, there would be savings to businesses, and it's argued that those businesses could turn those into increased wages. Now, we don't expect employers to necessarily do that automatically, but it's something that workers could be asking their employers to do if they didn't have that burden of having to pay such high costs for their health benefits. For unions, often with most strikes and also contract negotiations, it's often about the healthcare raise. It's wages, it's working conditions, but a big part of it is usually fighting to maintain their current healthcare benefits or to not have to increase the amount of money that they have to contribute into those healthcare benefits. So this would take, National Improved Medicare for All would take that off the table. Unions would no longer have to worry about that. They could focus on the other things that workers need in order to improve their working conditions. And it would take an important tool that employers have to subvert strikes. So it's not unusual when folks are going on strike or talking about going on strike that the employers will pull their health benefits as a way to force them off, to get off the strike, force them into negotiations to concede for less than what they deserve. For businesses, particularly small and medium-sized businesses, healthcare costs can sometimes drive them into bankruptcy or drive them out of business. So that would no longer happen. But if you look at, I think it's the National Federation of Independent Businesses, the number one complaint of small and medium employers is the healthcare costs that they have to deal with. It also impacts our competitiveness. So if you have one business that provides benefits to its employees, but the other one doesn't, the one that doesn't has an economic advantage over the one that does. So this would level that playing field. Also, internationally, businesses in the United States have to compete with corporations in other countries that have healthcare systems, so their healthcare costs are much lower. But it really puts a stranglehold on businesses in the United States. It would also make it easier for people to start new businesses, not to have the hassle of thinking about health benefits for their employers. And, it would make healthier workers. Workers would have access to care in a timely manner, wouldn't have to worry about paying for it. So you wouldn't keep putting it off, as so many people in the United States do. So hopefully what that would do is lead to a healthier population, which means healthier workers. And then there are studies that look at the impact on jobs. It's believed, because we spend so much of our gross domestic product on healthcare, that if those costs were reduced and under a national improved Medicare for all, it would lower overall spending by hundreds of billions of dollars a year. That could be have a positive impact on the economy, and that helps everyone. Studies also show that folks being able to have more money in their pocket and spend that, because most people in the United States have unmet needs. As we saw, when folks got their checks during the pandemic, most people were not putting that in the bank. Most people were spending that on things they needed, like rent or food or clothing. And so when people have increased discretionary funding and can spend that to buy the things they need, they're actually stimulating the economy, stimulating more jobs in their communities. For folks who are have to stay at home, quit working to take care of a loved one, under a national improved Medicare for all, covering in-home care and long-term care, means that people would be able to go to work and have health professionals taking care of their loved ones at home, or if needed in a facility. And it also means better jobs for healthcare workers. So many health professionals, nurses, physicians have left direct patient care because of their frustration with the healthcare system and gone into administrative jobs. Our healthcare administration is huge in the United States, the number of people that are working in that. But they leave direct care so they can go into these 9-to-5 jobs that have decent pay. Many of them would like to work. I know when I left practice, it was a little reluctantly. I would have liked to continue giving care, but I was just incredibly frustrated with the way that the system was. Under National Improved Medicare for All, we could draw people back into the healthcare system, into providing direct care, and we have a need for more direct healthcare providers. And I think people would be more satisfied actually providing care to people than they would being denying care to people, as people who work in health insurance corporations are forced to do. So let's talk a little bit about healthcare workers. And one of the demands of a national improved Medicare for all system is that there would be a just transition. So people would lose their jobs. People who work for health insurance companies and other private corporations would lose their jobs under National Improved Medicare for All. But what we have in some of the legislation, and I know it's not quite adequate, it's not as robust as we would like to see it, and that's something we need to demand. But folks who lose their jobs would be prioritized to be hired back into the new system, and those who are not hired back in would get job training and salary support so that they could transition to another line of work. For folks who are currently working in healthcare, the model that we have right now treats healthcare as a business and not as a service. And the business model means you try to get away with the least amount of staff that you can, the fewest workers. You try to get away with the least supplies. The business model, tries to just kind of keep on hand what they think they might need, but they tend to keep the inventory restricted. That would go away under National Improved Medicare for All. The hospitals and various facilities would get a global operating budget. That means they would have the money to hire the staff that they need. They would have the money to buy the supplies that they need under National Improved Medicare for All. As a single purchaser, we call this a monopsony. The system would be able to negotiate for fair prices for the goods that it needs and buy those in bulk. So that would reduce the cost of supplies and no longer have that kind of demand to just have a slim amount of supplies on hand. Also, for health professionals, it would return greater autonomy. That was one of the frustrations that I had as a health professional, was that I would see a patient, and with the knowledge that I had and all the years of study and training that I had, I would make a decision about what care they needed. And then I would run into an insurance company that said, no, they can't have that care. And you find yourself arguing with somebody who has no real medical knowledge. It was incredibly frustrating for me. And sometimes I had to really, fight back. And sometimes when I worked as a hospitalist, fortunately, the hospital administration did care about the patients in our population, and they would sometimes have to say, I can't send this patient home. I can't send this child home. You're just gonna have to figure something else out. That was, 30 years ago, or 20 years ago. Things have gotten worse since then, but just having that autonomy, having that respect for the knowledge that you have as a physician would be, a huge improvement for health professionals. Also, one of the things that I find really egregious is that physicians have to be so careful now about what you write in your charts, because you may write something that means that your patient is not going to get the care approved that they need. It impacts the way that we communicate with each other. And we know that as people, see various physicians, the more information that's in their chart for the other doctors to see or health professionals to see means better care for the patient. But doctors, have to leave things out because they're worried about the impact on whether that would help their, their patients would get that care paid for. Also, the amount of paperwork that we have right now. Our electronic medical record system was not designed for patient care. It was designed for billing. And I know, physicians now are spending so many hours on the computer. Hold on, speaker. Filling out, just churning through paperwork. And this would be a much more streamlined system under National Improved Medicare for All. There would be one system, one set of rules, and we could design it to be focused on health, the way that we chart and communicate with each other. Another thing is that sometimes, and this happens in other countries, you may have an unusual patient who may need care that's not quite what the standard care would be. And in other countries, when that happens, what you end up doing to get authorization for that care is that you talk to other health professionals in your field or specialists in the field, of what that patient needs. And so it's all about, well, you can say what you think the patient needs, and they may say, well, that's good, but have you thought of this? Or maybe this would be better. A friend of mine who was in Australia, his son had cancer. He got approved for surgery for the cancer, and then the system came back shortly after that and said, you know what? We have another hospital. It's a little bit more expensive, but they have better outcomes. So we're actually going to send you for care at this other place because we think that you'll do better if you go there. Imagine that. That just doesn't happen very much in the United States that I'm aware of. Also, physicians now are, they were really cogs in the system. I know so many people in practice who worry about their numbers, and each month you get your numbers. How many patients did you admit? How much revenue did you generate? And physicians are stressing about that. Well, there would be no more of that, no more pressure, no more hospitals saying you didn't admit enough Medicare patients this month, you didn't admit enough patients with private insurance this month. Doctors are pushed into providing less care. I know a very good doctor in Baltimore who had a hospital-based practice. Many of his patients were Medicaid. They had insurance through the system that the hospital was part of. We now have hospitals that also are insurance providers. It was a Medicaid MCO. And because this doctor was providing care for his patients that they needed, the hospital decided it was too much care. And they dropped him out of the MCO, and he lost all of his Medicaid patients. He was punished for giving them the care that they needed. We also see hospitals, and there was a story coming out of Louisville, Kentucky recently of patients being literally wheeled across the street from the hospital. We know this has been going on for a long time, and dumped on the sidewalk with their belongings in their hospital gowns. No care, nowhere to go. Well, in a national improved Medicare for all, the hospitals would have the funds that they need to provide care for everyone. There would be no reason to be kicking people out. And I think my next topic is infrastructure. We would have the funds to be able to start building up our healthcare infrastructure in the United States. As the population in the US has grown, we've actually been reducing our number of hospital beds. So I think in 1975, we had, around 1.5 million hospital beds in the United States with a national population of about 215 million people. Here we are now, we have fewer than 1 million beds, but our population has grown to be somewhere like 320 or 330 million people. So we have a serious lack of beds, and we have a problem with hospitals closing, particularly in rural areas or in low-income urban areas where they're not able to, quote unquote, make a profit. Under a national improved Medicare for all, each facility, as I said, would get that budget. They wouldn't have to worry about whether they're making a profit or not. They would be able to stay open, and we would have as a system an incentive to build out our infrastructure to make sure that our population is getting the care that they need. We also need to think about our healthcare workforce because we have such a lack of primary care physicians in the United States. And there's a study that looked at medical students and found that a high proportion of them coming into medical school wanted to go into primary care. But as they go through medical school and they accrue their debt, that drops off. And in fact, the year that the Affordable Care Act passed in 2010, when everyone thought that this was going to fix the healthcare system, the number of medical students going into primary care actually increased. So we're driving our medical students away from primary care, and also with primary care, the pay is not on par with the care for specialty work. We would have or be able to maintain full service hospitals. In Baltimore, we find that hospitals are closing obstetrics departments, pediatrics, psychiatry, because those are not money makers, and they're pushing more to open up cardiovascular and orthopedic centers because those will make a lot of money for the hospital. And we could move more towards, because the way that a national improved Medicare for all would work with its capital investment is that a hospital would have to apply to get an expansion or get new equipment. And what we find right now is kind of this technology race where one hospital might get a new technology and start advertising to get patients to come to their hospital for this new technology. And so the hospital on the other side of town is like, oh, look at that. We need to get that same technology so we can draw those patients here. And we know from studies that when you have a team of health professionals that's providing a certain type of care and they do it frequently, large number of patients, that they become more efficient at it, they have better outcomes. And so what we want to really do is move towards centers of excellence. So maybe one hospital has a certain technology and they build an expertise around that. Another hospital could have a different technology, and focus on that care and doing a good job of that. Also having access to data under a national improved Medicare for all. So much of our health data in the US is proprietary. It's not shared, but we would have a way to really collect that data and look at what's going on in our country, what's going on in various regions. There may be things that we need to be, interventions that we need to make in order to improve care in a certain region. We may see that certain diseases are on the rise and then be able to prioritize our healthcare so that we can start to move towards addressing that. And that brings me more to kind of like innovation. People often are concerned, well, what would a national improved Medicare for all do to innovation? Well, imagine, right now, medical devices are developed. They may not even be an improvement over what we have, but a company makes something, they make it sound really flashy and great, and they go out and they market it very strongly. It's about profit. Can we make a profit? But what if our medical innovation was about needs? What if we could say, these are the things that we're seeing, the problems we're seeing. We need to address these and really start to focus on that, as well as, pharmaceuticals. We see that so many of the new pharmaceuticals are really just tweaking things that we already have, and they don't have to prove that they're better than what we have. They just have to prove that they're better than placebo. So we could really prioritize the pharmaceutical development and focus on things that we need. And we're also, related to that, we're seeing shortages of basic medications because they're not profitable for the pharmaceutical companies to make. Well, under a national improved Medicare for all or a national health system, we could make sure that the various antibiotics, the various medications that we need are being produced and available. Thinking about the pandemic and how different it would be if we had a national system where we could, during the pandemic early on, you'll probably remember hospitals were fighting with each other to get the supplies that they needed. We were reading about hospital CEOs making, secret deals and delivering supplies in trucks that were not marked as medical trucks, trying to get the masks, the ventilators, the other protective equipment that they needed. Well, under National Improved Medicare for All, we wouldn't have these areas fighting with each other. The system would be able to say, oh, look, this is what this hospital needs. Let's send those supplies to that area. Similarly, we saw in other countries, where they would mobilize their health professionals to different areas of the country during the pandemic based on, where they saw the greatest need. And then finally, I want to talk a little bit about health disparities and how a national improved Medicare for all would look at, deal with that. And there was a recent study looking at health disparities in rural versus urban populations, and found that of 10 wealthy nations, the United States performed the worst. So we had greater disparities between our urban and rural populations. And as I said earlier, a big part of that is the closing down of rural hospitals and people just not having that access to care, having to go farther for care. So under National Improved Medicare for All, we could look at our infrastructure, determine where we need to put in new facilities and try to start to deal with that. We also have real disparities between the wealthy and the poor. And, we often talk about, Medicaid is a poor system for poor people. You don't have, not everybody's in it. So there isn't that incentive. There's not that solidarity, that feeling that, people are kind of okay with, oh, well, those are poor people. They don't matter if they don't, they're getting something, so they should be happy with that. But if you had a National Improved Medicare for All, every single person is going to be in that system, and there's going to be a demand to make sure that that system is high quality. And as people are pushing for that to be high quality, that means everybody would have access to high quality care. And then, we really have to talk about racism in our healthcare system. And if you go to my website, popularresistance.org, in the slider at the top of the page, you'll find, if you go through it, that there is actually a presentation on racism in healthcare. And I advise you to take a look at that because, there's no genetic basis to race. It's not the color of someone's skin that is determining why they're having worse outcomes. Why are Black infants dying twice as much as white infants in the first year of life? Why are our Black mothers dying 3 to 4 times more than white mothers in childbirth? Why are children with asthma, Black children with asthma, having dying 5 times more than white children with asthma? This is not because they're Black children, it's because of the way that our healthcare system treats them. And so the VA did a large study looking at like 1 million patients and found that in the VA system, which is a national health service type of system where everybody has access to the same care, that Black population actually performed better in terms of heart disease. And if you look at the general population, it's the opposite. So in a single payer system, the outcomes were better. And part of this has to do with training and what's called the medical gaze. We have studies looking at physicians who were given descriptions of patients that included race. And they found that if the patient was Black, they often attributed certain characteristics to them, didn't, prescribe the same level of care, but also our own protocols will disadvantage people if they're Black in the United States. So that's something that we need to be dealing with in our system. And I think if we could get the other step out of the way, these are the fights and the struggles that we could have to make sure that we're changing our system to really deal with these healthcare disparities. Also, what we find in other countries that have national healthcare systems is that it starts to have an impact on public policy. Now that the government is responsible for paying for the health of the population, they're going to be a lot less likely to put a polluting industry in the middle of a community. They're going to be more likely to invest in public health measures. We see in what's a Scandinavian country, I think it might have been Finland, that had very high rates of heart disease, and they started investing in all kinds of parks and walking trails and public education about getting exercise, and found that as a way to try to improve their health outcomes. So we would see, an impact on our public policy ripple out from having a national Improved Medicare for All. We could also start to have a system that people trust. Right now, there's very low trust in our healthcare system, and with good reason, there's low trust in it. But with a public system that could be accountable, transparent, there would be, we could start to build towards better trust in that system, a system that's about health and not about profit. We could start to rebuild that trust in the system. And finally, under National Improved Medicare for All, when we win this will be a huge gain, a huge victory for the people. And I think it's one that would inspire us to have the other fights that we need to have, to see that we're victorious. One of the things that gets me is that we've already won the information battle, despite the disinformation, the demonization of a national Improved Medicare for All in the media. We still have a majority of the population and a growing majority of the conservative population that supports it. What people don't believe is that we can win it. And so when we win this, it's going to be a huge encouragement for people to recognize that now we can fight for, better working conditions, better housing conditions, more social housing, better education, better food, all of the things that we need in order to live a healthy life. I hope that it would inspire us to have those fights and succeed at those as well. So I'll stop there. I look forward to your questions. Thanks.
Okay. Well, we've had a very active chat going on. Just to introduce myself, I'm Judy Albert. I'm one of the steering committee members of National Single Payer, and I'm also a board member of PNHP. And I have been organizing the questions, and some of the comments I'm actually going to use as questions if Margaret will indulge us on some of those. So first of all, from Cheryl Van Epps, she would like to know, have you read the text of the Senate Bill 1655 or HR 3421? That was the question. There are other specifics about the bill that come out in some of the other questions too.
Yeah, so I read them in depth when they first came out a number of years ago. I've not read the current iterations, but I've read and written about the previous ones. So I do have some familiarity. I know I talked to Dr. Malinow recently, and it sounds like there've been some changes, but overall the things that we're concerned about haven't really changed. There've been some improvements, but there's still some flaws.
Yeah. The next question is, why is national the only path? And there are several iterations of this question. It occupied quite a bit of the chat. So I know you have a lot to say on that.
Yeah, and I've written and spoken about this as well. And I think there are a few things that really stand out. One is that a state cannot actually, under our current law, create a single payer system. There are, the federal employee health benefits, TRICARE, which is for the military benefits. These are all private. The VA system, Medicare, Medicaid. Well, Medicaid is a state system, but there's a lot of federal programs that states would have to get waivers or changes to the law to be able to roll those in, and it's not clear that those populations would want those rolled into a state system. There's also the ERISA, Employee Retirement Income Security Act, which basically prevents states from being able to regulate employer insurance. And there have been a few court cases in the last decade or so around this. And they've always come down on the side of the employer. I think in Vermont, there was an effort just to get access to the data of the, I'm sorry, 1 second, let me just deal with my son. Of how the healthcare benefits, what was being kind of, how those benefits, what services I think the employees were getting and things like that. And they lost that. The law came down on saying, no, the employers don't have to share that information with the state. So there's a lot of barriers that way through the law. And if we're going to have a fight to change federal laws to get a state system, why don't we fight to, instead to get a national system that everybody's in? The other really big one is the budget. State budgets are restricted. They have to balance their budgets. The federal government doesn't have to do that. The federal government can appropriate money, can make money. So a state, if you have a few very high, very expensive patients, you're going to find that the state is going to run into budget problems. They're going to have to start making cuts to their system. And then finally, the last thing is we're not trying to create 50 different state systems. I think there's a misinterpretation of the way that things happened in Canada. And people often say, oh, well, it went to one province and then it went nationwide. That's not exactly how it happened. What we would end up with is various states with different systems, and you'd have some states with good systems and some states with really bad systems, as we see right now with Medicaid. And that's part of what's called the Southern strategy that people talk about. Historically, because of racism, for these types of decisions, they tried to push it off onto the states because they know that there would be discrimination if you let the states make those decisions. We want a system that every single person is in, no matter where they go in the country, and that they're all getting the same level of high quality care. And so that's why we fight for national.
So some of the frustration that comes across in the chat from various people that are supporters of state bills is expressed in this question that was posed by Larry Gross and Scott Tucker. I'm not sure if they're both on the call on the same screen, but that's how it came in.
I know who they are. Yeah.
They'd like to hear anything about how national single payer might be achieved and why it's not feasible to obtain single payer in a few states as a model.
Well, I mean, one thing, like I said, say a state passes a bill for single payer, then they're going to have to put a lot of their fight into implementing that bill. And that's going to pull those states out of the fight for national. So we hear in so many states, well, we can do both. We can fight for state and national, but you can't really do both. You only have so much time, and your strategy is going to be different working for a state versus working for a national. So say California passes a bill or New York passes a bill. Now we've lost some big players from our national fight who are going to be focused on those state systems. So I think that's another reason why, we really, if we want to win a national improved Medicare for all or a national health system, which is what I want to do, we are going to do that by focusing on that, by developing a strategy to win and putting our energy and resources into that. And I believe that we can do it, and I will tell you why. Because in 2009, when we had the healthcare fight around the ACA, I was part of a large coalition that was pushing to get single payer into that debate. And we were not a big group. I mean, we represented a lot of people, but the folks that were actually on the ground doing the work was not a lot of people without a lot of resources. But by being in Congress every day and educating the staff, educating the members of Congress, and then taking direct action. So Claire mentioned at the beginning my arrest in the Senate Finance Committee. That was not my only arrest during that period. It was not the only arrest that happened. There were a lot of people taking direct action, putting pressure, also holding demonstrations. And because of that, we had a single payer amendment in the House that would have switched the ACA for single payer. And Nancy Pelosi pulled that from a floor vote 36 hours before they had the vote in the House. That was problematic. But in the Senate, Senator Sanders introduced an amendment. It was an 835-page amendment to replace the Senate bill with a single payer bill. And it was amazing because it was December 16th, 2009. We had noticed that, who was the guy, the Nevada guy that was the chief, the head of the Senate, Harry, I'm
Reid.
blanking on his.
Harry
Yes,
Reid.
thank you. So Harry Reid was taking the amendments to the healthcare bill by number, but he skipped over Senator Sanders' amendment. So we engaged in direct action, confronting the members of Congress directly over that. We had media, national media following us around with this. That was on like a Thursday. The next Monday, we get a call from Sanders' office. They're going to introduce the amendment. They introduced it, and then there was a maneuver that was used to require that it be read, 835 pages. This is like December, they're trying to go for winter break. The president is putting all this pressure on them to pass the bill before they go on their break. So Reid cut a deal with Sanders. That's how he got the money for the community, the primary care stuff. But for 3 hours, the single payer legislation was being read in the Senate on C-SPAN. You could read it. I remember I was running back and forth between the Capitol and the Sanders office and making phone calls, and we got it to the floor. That was the first time that a single payer bill had ever made it to the floor. If we could do that with a small group of determined people, imagine what we could do as you're doing, as you build this movement, as we focus on the national, we think about strategy, we stay on top of what's happening, and we respond to it. We can win this. Sorry, that's my soapbox moment. I hope I answered the question.
No, that's great. And it's really important to remind people about that time, because a lot of us have forgotten or weren't present when that was going on. Along the lines of the difference between state and national single payer, the other question that came in a few times is how would it be funded?
So that's something that's not in the legislation, but the United States is like one of the most regressive healthcare financing systems in the world, so that people with low incomes pay a higher proportion of their income for healthcare than people with higher incomes. We need to reverse that. I think still about 2/3 of our healthcare spending is public dollars. So we could keep that. And then we can decide how we bring in the rest of the money that's needed. There are lots of different proposals for doing that, but I think what's really important is that as we talk about that, it needs to be done in a way that that doesn't put the greater burden on people who are already burdened and struggling financially. But I work on a lot of different issues in addition to healthcare, and I've been in Congress a number of times and sat in on the hearings. And it's like someone will say, we need $500 million more for the military. And they don't even blink an eye. They're like, okay. I remember one time I literally got up and walked up to the well and said, we need that money for healthcare and education, not for, more military. And I got dragged out of that. But, it's not a problem. Congress has no problem appropriating money for more military. And every year they give millions more than what, the Pentagon even asks for. And we don't even know how the Pentagon is spending it. They can't even pass an audit. So I think that Congress could, with public pressure, they could find a way to fund this so that people are not burdened.
So getting into, again, some specifics in the bills, Cheryl asked if in the bill, patients are given protections against medical harm, and are we all as individuals guaranteed transparency of our care plan? Does the legislation follow patient-centered care directives?
So I know in the Senate bill, and Anna could probably respond to the House bill better than me, that there was very strong language about not being able to discriminate in our healthcare system, and systems for people to, if they felt like they weren't getting the care that they need or they were being discriminated against, could make a complaint about that and get a response. There were mechanisms for that in that legislation. Maybe Anna, you can say if it's that way in the House bill as well. I imagine
Yes,
Yeah, that
they're compatible in that way.
Yeah, yeah. In terms of transparency, I mean, the system that we have now is completely not transparent. In a public system, that would be a hope, is that this is our system and we have the right to our information. You wouldn't have that profit motive standing in the way to prevent people. But actually, in reality, there are laws right now that allow us to get access to the information. You have to make requests and go through a process to get your healthcare information. And you can get information about how the insurance companies are making their decisions. This is a little used tool that ProPublica did an excellent piece on, outlining exactly how you could do that if you're denied care, and urging you to first make these requests to get the information about how that care was denied before you start fighting back, so you have an informed fight back. But I don't know, again, Anna, maybe you know if there's specific language about transparency in those legislation. I don't recall it being in there.
Right off the top of my head, I don't remember that. I can't say.
Yeah.
I don't remember specifics about transparency. I mean, there's some other things for about what's it called? Decision making that is in there, but it's not very specific.
Right.
So another question is related to the fact that our US style of healthcare is now being exported to other countries, especially the UK. Can you elaborate about what you think might happen to corporations that are trying to harm healthcare around the world if the US were to ban them here?
Yeah, you know what I think is really interesting, particularly with the United Kingdom, where it's been under attack, their healthcare system with cuts, funding cuts, and then trying to push in privatization. We know that the US government, members of Congress, are closely allied with these big corporations, these very wealthy transnational corporations, and act in their interests. And so the US government has actually been trying to push, help those corporations get into the United Kingdom. So if we didn't have that going on here, I don't think that we would have that incentive for our government to make those types of intervention on behalf of the corporate interest. So that would take some of the pressure away from that. Also, I think of another mechanism that is used that the US is behind is, if you think of the International Monetary Fund, when countries get loans, through the IMF, they also come with what's called structural adjustments. So these are requirements that they have to make in order to get the loan, and it involves them cutting back on their public systems, public healthcare, and others, in order to it basically is as meant to open the door to privatization of those systems. And again, it's those US corporations that are coming in and privatizing. So without that going on, I think the IMF, that we wouldn't see that kind of pressure happening either. So I would anticipate, and maybe others have,
So this is Dr. Cohen. I would like to say something about that. So there was a time when a number of third world countries were experimenting with single payer type and national healthcare type services. I'm trying to think. I know Rwanda was one. I'm trying to remember. And you may notice now that all of those are gone, and those are all gone because of those IMF structural loans, which required them to get rid of their national healthcare programs and their national and their single payer programs in order to restructure their loans. And that's how they got rid of national single payer and national healthcare programs in what's now called the Global South.
right. And look what we're doing to countries that have these systems, like Venezuela or Cuba or Nicaragua. The US has been at war with them, an economic war on them. How dare they use their resources to provide for their populations? We don't want people to find out that can happen, So yeah, thank you for sharing that, Claire.
So also on the topic of privatization, we're seeing this huge influx of private equity and venture capital in all types of clinical settings. If we had the national single payer, what would prevent those firms from setting up business like they have today already in nursing homes and dental clinics and clinics for kids, and siphoning public money into their private coffers? And at the end of the day, is this really an argument for a national health service?
Important question. So we have to look at the difference between National Improved Medicare for All and what a national health system would be. And National Improved Medicare for All would mean that the government would be the payer. So that's why we call it single payer. So the hospitals, the doctor's offices, although those have mostly become corporatized these days, would bill the government for the care that they provide, but they would not be owned by the government. And what we're seeing right now with Medicare and Medicaid is this huge privatization of them through the Medicare Advantage, now through the ACO REACH program, those are owned by private equity, who have no concern about the health of the people that are covered by those systems. It's what they can suck out of them money-wise. And so now we know that the top health insurance corporations are getting most of their revenue from the government through these privatized Medicare and Medicaid programs. The government is a guaranteed payer, so it's like a cash cow for them. They all want in because that's where they know they can get the money. We need to stop that. I mean, I'm actually a supporter of a national health system because I think, and if you look at the two pieces of legislation in the Senate and the House, neither one of them ban the private. David Himmelstein and Steffi Woolhandler did an excellent piece a number of years ago showing how the United States could buy out all the private health facilities and it would be very affordable to do. And you would make sure, and that's what HR 676 had, it would buy out the for-profits. The current bills don't do that. They leave them in there. And I think they will just be trying to keep getting more and more of that pie. If you try to keep them in and say, well, you can stay in, but we're going to put restrictions on how much profit you can have or money you can make, that's just not going to fly. They're going to leave. They're going to say, we could sell our hospital for condos. We can sell it for retail space, as we're already seeing. Hahnemann in Philadelphia, I think St. Vincent's in New York. So I think that if we truly want to have a healthcare system that doesn't discriminate, that serves everyone, that's high quality, we have to get the private for-profit out of it. The current legislation doesn't do that, and even if it did under just a national health insurance, there might still be, problems there. They'd still be trying to get in there. Because also we see the so-called nonprofits behave just as badly as the for-profits. So I think we really need to talk about, things have changed over the last few decades, and private equity has taken such a foothold in consolidation of our healthcare system into private hands that I think we really have to have a serious discussion about a national health system.
So I'm going to switch a little bit to talking about impact on retirees. A couple of different approaches to this question. First of all, Bill Farmer asked, what financial effect would Medicare for All have on retirees living on pensions, Social Security income, et cetera? And then it was also a question about the mobilization in New York City by the municipal retirees who are being stripped of their rightful Medicare Part B plans and forced into accepting Medicare Advantage plans. So could you elaborate on both the first question as well as what's happening to the health plans of retired public employees, and how are these retirees fighting back? What could we learn from them?
Yeah, thank you. So the first part of the question about what impact would National Improved Medicare for All have on retirees? Well, right now, retirees in Medicare, as I said, it doesn't cover everything. It doesn't cover hearing and dental and vision. There are some out-of-pocket costs that you have to have, and seniors have to have supplemental plans. They have to have pharmaceutical plans. That would go away under National Improved Medicare for All. It would be comprehensive. You wouldn't need to have supplemental insurance. So that would be a huge, improvement for everyone. And then you have the Medicare Advantage plans, which are, I remember President Obama saying that he was going to rein in these Medicare Advantage plans through the ACA, and absolutely the opposite has happened. We're seeing more, them getting more of a bigger piece of the pie. And these Medicare Advantage plans, well, as many of us know, they cherry pick. They have ways of identifying seniors who are healthy. They go into senior centers. I've had this experience with a family member in New York. They went into the senior center, and they're not supposed to do that. They're not legally allowed to go in there and enroll seniors, but they went right in there. And these are seniors who are healthy enough to get out and walk to the centers and do the activities and things. And they convince them that their plan is really wonderful and better than what they have, and they should go into it. So they bring in these healthy patients, and then when they have a serious health problem, they're not able to get the care that they need. I also had that experience with a family member who had a very serious stroke and wasn't improving fast enough. And so, and I asked the doctors and the therapist, would you expect this person to improve faster? And they said, no, not necessarily. But because he wasn't improving fast enough, they kicked him out. It's really, the things that are happening are just, if people in the United States understood that this is not normal, everybody would be up in arms. And so, so seniors wouldn't have to worry about that anymore. You would be able to get the care that you need. So I think that would be a huge improvement for folks, and the lower cost to them, the security, that health security. What's happening in New York, and I understand it happened in Vermont. I don't know a lot about the Vermont story, but in New York, the mayor wanted to switch the pensions for the retirees, put them all into an Aetna Medicare Advantage plan, take away their traditional Medicare or their right to have traditional Medicare. Because many times when seniors have a serious problem and they're in the Medicare Advantage plans, if they're able to, they'll switch back into traditional Medicare. And that happened to one of my family members as well. Fortunately, we were able to get her in when she had an accident. She was hit by a motorcycle and needed rehab. So the mayor signed this deal with Aetna to put all of the employees into this private Medicare Advantage plan, and they immediately responded with a rally at the city hall, educating people, and then they pursued a legal challenge to it. Unfortunately, they won that recently, and so that has stopped the city from putting them into this Aetna Medicare Advantage plan. These are important struggles. I think we need to, and it's the same thing with Medicaid. We know that Oklahoma had a fully public Medicaid system. It functioned very well until they dismantled that. Connecticut has had a fully public Medicaid system for quite some time. It's lower cost, better outcomes. They're able to invest more of their dollars into building out their infrastructure and care. And that was due to a legal battle there. And it's a way when we take on these struggles to make the point to people in a real tangible way, why privatization is bad, why we need public health systems that are about health. So I think these fights are important, and for us to be supportive and in solidarity with them, we have to keep our eye on national Medicare for all. But these are ways to build our capacity to reach people and to raise awareness of this idea of why we're defending public health, public health care. I hope that answered your question.
Another question from Ed Gristar. How would National Improved Medicare for All be an uplift for the working class, for minorities, and for women?
I talked a little bit about this earlier, but again, it's what you find in other countries that have universal healthcare systems is because everybody is in that system, and because it's one system, there's a strong incentive to fight to protect it. Those systems are constantly being tweaked, improved. You know, we can't take our current system and tweak it because it's just fundamentally flawed. There's no incremental way to win this fight. Actually, I see National Improved Medicare for All as an incremental step, the smallest one that we could take towards getting the healthcare system that we need. And actually, when Howie Hawkins was running as the Green Party candidate, I can't remember when that was, the last, I guess 2020, I helped to write his healthcare platform. He asked me to, and we wrote it as, here's the first step, National Improved Medicare for All, right away. Just say everybody's in, we already have the infrastructure for that, it wouldn't take much to do. And then over a period of time, building towards a national health system that has democratic control, local democratic control, where local populations have a mechanism of having input into their what's covered, what facilities are there, what those facilities cover, how their care is delivered. That's really important. Sorry, I'm getting off on a tangent now in my mind. I think I've been talking for too long. It's starting to go. Remind me again what I would.
Just the whole idea of, you know, how everybody would benefit,
Oh,
but
right,
particularly
yeah.
people that
Right,
are
so,
hurting.
right, so if you have that solidarity, the incentive is going to be there to make it a high quality system, and that really benefits every single person. I mean, I think for women right now, we know that women have to end up paying more for their care than men do. We have a lot of needs for reproductive care, and so that would, women would not have to worry about that. And then that's on top of the fact that women typically earn less than men do. So it's an added burden for women. In what we're fighting for is that every single person in the United States, if you are living in the United States, you're in the system. We don't want to leave anybody out, and we wouldn't. I mean, if you were walking down the street and somebody suddenly collapsed in front of you, you wouldn't decide, oh, well, maybe this person doesn't get health care. Your first thought is, we got to take care of this person. That's what it needs to be. Every single person in our country would get care. And then, as I talked about earlier, we really need to look at health disparities and systemic roots of those health disparities, and how do we address those? And there's a lot of work to do in that. And I know one of the profound experience that I had in Congress back in 2009 or 10, they had these multi-stakeholder meetings in Congress often, where they brought in, various people to seek their input. I mean, it was all a charade. It was all for show, because you always had the health insurance representative speak first, and they would say, well, we can only do this if everybody has to buy our product. And then you would have, the businesses get in there and be like, well, we don't want to have to pay more money for this. Or then they would leave the room. And then you'd have all these people that represented advocacy groups for various sectors of our population. And they would send, you'd hear all of these amazing ideas of ways that we could be improving our healthcare system. And I think if we move to a National Improved Medicare for All, that's what it would do. It would unleash the power of people to focus on ways that we could actually improve the system for everyone. And then I think I talked a lot about how it would benefit workers in terms of taking that off the table, so that we could focus our fights on better wages and better working conditions, for workers.
I think I'm going to finish up with maybe one last question. We've gotten through most of the questions that were placed in the chat. And this comes from Ed Clunan. And the question is, how does the leadership of both political parties ever reconcile their appetite for continuing contributions with any consideration of healthcare for all without profit? In other words, is there any political path forward?
That's a huge question.
Yeah, a nice one to end with, right?
Yeah, I mean, our political system is really dysfunctional. It operates for the wealthy. We live in a plutocracy, and we have to recognize that. We live in a mirage democracy. I've written about this as well. We have the illusion that we're participating in a system, but honestly, the candidates are pre-selected, and they're also selected on the basis of money. It makes it very difficult for people to challenge the establishment candidates in this system. And I've had experience as an international election observer down in Venezuela, and also meeting with like I met with the head of their National Electoral Council. It's the fifth branch of their government. And there, the barriers to participation were much lower than here. And in their elections, they would have more than 100 political parties participating. And you didn't have this concentration of wealth so that, certain parties dominated everything. The system is broken here in the United States. And this is a lot of the work that I do at Popular Resistance, is that we have to, we can put pressure on the system. We can have wins. We have had wins. I've also had experience in Nicaragua and talking with the folks there that organized the Sandinista revolution, and they've made amazing gains. And they have what they call revolutionary discipline. They take it very seriously. They understand what they're up against, and they put in the work to change it. They understand the politics of the system and what they need to do to challenge it. And that's the political sophistication in the United States compared to these other nations, I feel is very low. And so education is critical about how the system operates, how we change it, how we put pressure on it. We can put pressure on it. It comes through being willing to engage in direct action, in strategic campaigns, focused on, specific things that we can target. These are conversations, and it's why I so often say that we need to build bridges with our brothers and sisters in Latin America who have already waged the struggle, because we have so much to learn from them. And I don't, so many people say, well, if we just got the money out of our system, but no, we have to change the whole system and make it one that's oriented towards meeting the needs of people and not the needs of the wealthy. And that comes through the traditional education, organizing, and mobilization. And that's what it falls back to. And that's what we need to be doing. That's what you're doing. And that's why I'm so happy that you're doing that. And while I've had a lot of challenges recently, I'm with you and will be with you forever and do whatever I can to push this struggle forward.
Well, thank you, Margaret, as usual. It's been a great presentation. You probably couldn't look at the chat, but there was a lot of dialogue going on there as well. And I think we got some great questions and also perfect answers from you. I'm going to turn it over to Anna to wrap things up because it's getting kind of late tonight. So thank you again so much.
Thank you.
Well, thank you, Margaret, for everything, really. You've been talking for a long time, and I appreciate that. Nevertheless, we've all been on the edge of our seats, really, because we just love to hear you and everything that you say. You're so inspiring. You have such a wonderful history and experiences, and we just loved hearing about that. I know that I did. So I do want to thank you. I also want to thank our participants for hanging in there, for participating in the chat, for asking questions. I apologize for not having the Q&A, but we'll figure it out for next time. I think what Margaret, what you did is you really brought together so many things. First of all, you talked about all the benefits that we would have under a national single payer plan. And the benefits are so wide ranging. And that's the reason why I wanted us to have this conversation. So wide ranging, from obviously your employer-employee relations to labor, to other public policy, to the trust that we would have in our government, to the infrastructure, to the supplies, to the PPE, to innovation, to disparities, to racism, to what would happen under a pandemic, if what could have happened if we had a national single payer program. The ripple effects for other social justice issues is also really, really critical, and you brought that out, and I thought that was really excellent. And being a physician, you talked about bringing the joy of practicing medicine back. And I think that for those physicians that are listening, I think that having a national health program particularly National Health Service, but even just a single payer system, I think would make such a huge difference in the joy of practicing medicine. I'm sorry that I didn't get to do that in my profession, but hopefully in my lifetime that will happen if we keep working. So as I've said before, the health of our nation is held hostage to the profits of corporations, and that really needs to change. So for those of you that are interested in our work, please go to our website, nationalsinglepayer.com. We are trying to change things up a little bit, and so we are having educational sessions just like the one that Margaret just presented, alternating with our working group meetings, which are where we are actually doing the real work of activism and mobilizing. And our next working group meeting is going to be Wednesday, August 23rd at 5 p.m. Pacific, 8 p.m. Eastern. And so for those of you who would like to join us for our working group in 2 weeks, please go to our website, nationalsinglepayer.com, and you will be able to sign up for our working group meetings. I just want to let people know that the next time, if all you want to do is come to our educational meetings, that's totally cool. Next time that we meet for educational meeting is going to be September 13th, and that's going to be Linda Phoenix, who's going to be presenting a topic called The Backbone Gave Us Medicare. It will take courage to save it from privatization, how Medicare desegregated hospitals in the US, and how value-based schemes threaten to end a beloved public program. I encourage everyone to please join us for that as well. Now, for those of you who are interested in doing the local work that it's going to take for us to achieve national single payer, I put in the chat a little while back where we have state activists, and you can look to see if your state is mentioned, and if so, there is an email there with a name of a contact person. You can contact them to do the work there. We have people in Texas, Kentucky, Pennsylvania, California, Michigan, and Virginia. And if you live in a state that does not have an organization that is fighting for single payer or to end the privatization of Medicare, please join National Single Payer, and we will help you start an organization in your own area. So, Margaret, I don't know if you have any last parting words for us, if you can manage. I know you've been speaking for a long time, but just to thank everyone and send us off.
Yeah, no, I have tremendous appreciation for the work that everyone on this call is doing. This is a necessary fight. It's not something that we can give up on. And so, as I said earlier, we've won the battle of this as the solution. What we have to win is the battle of how we win it. And that's why I think national single payer is so important, because you have a venue, you're focused on national, and you're doing the work, and you can strategize. And again, just remember, you don't have to have a lot of resources to do this. Resources are nice, but these struggles often don't. What you need to do is to really focus on the how and the organizing and making it happen. And we will succeed. I mean, I hope we have to. The United States is becoming a failed state in so many ways, and this is one of the big ones. And so this is a fundamentally important and critical fight right now. And I'm so glad that you're waging it. Thank you.
Thank you, Margaret. And thank you everyone for participating. See you next time.